This is your blood and coagulation prescription and record form, or your transfusion prescription chart. This is the only place to prescribe blood and blood products. This is a legal document and must be completed in full to ensure the right blood product is given to the right patient as safely as possible. It must provide an accurate record of the patient's transfusion. This is also required during activation of the major hemorrhage protocol. The sections in grey are mandatory for doctors to complete. Nurses, midwives, ODPs, those administering the blood products must complete the white areas. Those collecting must complete the blue areas, and the areas in pink must be completed by any qualified KGH staff members. Red text sections are mandatory. The final nice quality statement is for patient information. Patients who may need or who have had a blood transfusion must be given verbal and written information about the transfusion. They must be given understand the risks and the benefits of the transfusion and why they are receiving the transfusion. The healthcare professional prescribing the blood products, so at KGH that is only doctors, must be giving verbal and written information to the patient. This is your professional responsibility. This should include the reason the patient is having the transfusion, the risks and the benefits of transfusion, what the transfusion process is, any transfusion needs specific to your patient, any alternatives to your patient that might reduce the need for transfusion, and also inform the patient that they can no longer donate blood once they've received a transfusion. Communicate fully with the patient, explain the reasons for the transfusion, ensure the patient is given a patient information leaflet. Receiving a blood transfusion covers transfusions of red cells, FFP and platelets. As previously mentioned, there are other leaflets such as irradiated blood products. Give this patient in good time before the transfusion starts. Give them time to read the leaflet. This does half your job for you. It explains to the patient what a transfusion is, the risks and the benefits of a transfusion. Also lets them know they can no longer donate blood. However, you must ensure that the patient has understood that information when you speak to them. If it's an emergency situation, you still need to ensure the patient receives this information retrospectively. If your patient lacks capacity but next of kin are present, ask the next of kin if they would like one. Each ward should have a stock of these patient information leaflets. If your ward doesn't or you need more, then please contact the transfusion team and we can get you some. Alternatives for transfusion. I'm not going to read all of these out. I'm sure you can read them for yourselves, but there's like iron, B12. The main one at the bottom there is tranexamic acid during activation of the major hemorrhage protocol, or those patients expected to have over 500 ml of blood loss during surgery. Intraoperative cell salvage, just to remind you that that is bookable. So you need to book intraoperative cell salvage and you need to contact the theatre coordinator to book cell salvage. Blood bank or the transfusion team cannot book cell salvage for you. You must gain consent from the patient for all transfusions. This section must be completed by the doctor for all transfusions. Informed consent must be obtained by the authorising or prescribing doctor before the transfusion. There is short consent guidance on the pink transfusion prescription chart on page 6. Inform the patient that they need a transfusion, why they need it, the risks and the benefits, which we've previously discussed. Give the patient an information leaflet, and then the top box there, I confirm the risks and the benefits and alternatives relevant to the patient have been discussed and verbal consent has been gained. I've provided the NHSBT receiving a blood transfusion leaflet. You tick that box, print your name, sign and date. If your patient lacks capacity, then you've got the box 2 there, impaired capacity. Tick that box and again print, sign and date. And for those patients on a long-term transfusion programme, so in this trust mainly haematology patients, you need to make sure that you have visually checked that consent has been obtained and documented somewhere, and then you can use box 3. For paediatrics and neonates, obtain consent from next of kin. This must be completed before the transfusion is collected and for every transfusion. As mentioned, there is short guidance on page 6 of the blood and blood products, coagulation products prescription and record form, but there is more guidance in the main HO2 policy available on net consent. Delays and pulmonary complications, TACO and non-TACO, continue to be leading causes of transfusion-related deaths in the UK. These two categories together account for 29 of the 38 deaths in 2013 reported to SHOT. If your patient requires a transfusion, please ensure they get it in a timely manner. Transfusion-associated circulatory overload, TACO, has been identified as a leading cause of transfusion-related morbidity and mortality in recent years. And on many occasions, it has been deemed preventable. All patients should be assessed for their risk of TACO prior to every episode of transfusion. Even if the perceived risk is low, a formal TACO risk assessment must be completed, and this is a requirement from the National Patient Safety Agency, MHRA. This assessment should include considering the patient's body weight, because low body weight increases the patient's risk of overload. Review the patient's medical history, especially cardiac, respiratory and renal. Review their current fluid balance. Are they already in a massive positive fluid balance? Consider infusion rates. You might want to give it a little bit slower if the patient has low body weight. Consider other fluids that are going. Has the patient got an hourly crystalloid going? You might want to consider stopping that whilst the transfusion's in progress. Consider frusemide. We don't routinely give frusemide with transfusions anymore, but for some patients it still has its place. For those patients that are on regular frusemide, check, has the patient had their frusemide? Some surgical patients may not have had their frusemide before surgery. Also check, if they are on regular frusemide, do you want to coincide the transfusion to go along with the frusemide? Consider 1 unit transfusions. You should be considering this for all non-bleeding patients. Clinically review the patient in between units and check their HB results. Again, you should be doing this for all non-bleeding patients. And add the volume to your fluid balance chart. The volume of the pack of blood is clearly documented on the fluid balance chart. All patients should be assessed for their risk of TACO and mitigation documented and implemented in the medical notes or on the transfusion prescription chart on page 3. This is the formal TACO risk assessment, which is on page 1 of the blood and coagulation prescription and record form. This must be completed in full by the prescribing doctor. You need to answer every question in this risk assessment. So, has your patient got heart failure? Yes or no? Is your patient on regular diuretics? Yes or no? Does your patient have severe anemia? Yes or no? And then on the right hand side there, if proceeding with transfusion, assign an action. So what is your mitigation to minimise the risk of TACO to your patient? If your patient has 1 or more risk factors, you must be implementing mitigation, at least starting the patient on the fluid balance chart. Review any mitigation required to minimise the risk of TACO and ensure that it is implemented. Then you must print your name, sign, date and time. Again, this is a requirement from the National Patient Safety Agency and MHRA. You must complete a TACO risk assessment for every patient, regardless of perceived risk. Just want to have a quick read of that SHOT report there. Okay, So prescribing of blood products. Blood products must be prescribed on your pink blood and coagulation products prescription and record form. This is a legal document and this is the only place to prescribe blood and blood products. Prior to prescribing the blood products, ensure that you have carried out positive patient identification. So get the patient to verbally state their full name and date of birth and check this matches your prescription chart. Ask the patient to visually check their full name and date of birth on the prescription chart if they are able. The prescription must clearly state the date of the transfusion, the product to be transfused, the indication code, any special requirements. Remember, you must state either what the special requirement is or none. Do not document unknown or leave the box blank or empty. If you are documenting none, you must be 100% sure your patient doesn't require a special requirement. Remember to check the medical notes, speak to your patient and check care flow for alerts. The dose that you're prescribing, you prescribe on a unit-to-unit basis for adults. In paediatrics, neonates, you prescribe in mils. The duration, please do not document a range. It must be a time. So either 3 hours, 3.5 hours, 2.5 hours. Then you must print your name and sign on the prescription. Again, never presume the person prescribing before you has prescribed the correct blood component. It is your GMC number. You must ensure you are prescribing the correct blood product, including any special requirements. The other grey box there below the prescription is on page 3 of the transfusion prescription chart. You must document the patient's weight, because you need a patient's weight to complete an accurate TACO risk assessment. So you need to document that you've checked it and what date that weight was. If you can't weigh your patient, then a guesstimate is better than nothing. And then you must document there, have you checked care flow for alerts? So does your patient require check care flow, irradiated blood products, yes or no, CMV negative, yes or no. But again, do not rely on IT systems or alerts to inform you that the patient needs a special requirement. Make sure that you check the patient's medical notes and speak to your patients if able. On the inside of your transfusion prescription chart, you've got your indication codes on page 2 of the transfusion prescription charts. This must be used for each transfusion prescribed to indicate why you are administering that blood product or why it's required. Certain patients refuse blood products. The main patients refusing blood products are Jehovah's Witnesses. Jehovah's Witnesses should be carrying on them an advance decision to refuse specified medical treatment or an advance directive, an advance decision. It's the same thing, just different terminology. These are provided by the Jehovah's Witness community. They are not provided by KGH, and KGH do not complete these with the patients. All Jehovah's Witnesses refuse the 4 primary blood components: red cells, white cells, platelets, plasma. Thereafter, it is a personal choice. So anti-D in pregnancy, personal choice. Cell salvage and surgery, personal choice. Octoplex, personal choice. So if your patient has capacity, then you can discuss the other blood products with them. If your patient doesn't have capacity and they have not documented on the advance directive that they also refuse cell salvage, anti-D, etc., then you just presume the patient refuses the 4 primary blood components: red cells, white cells, platelets, plasma. On admission, ask the patient for a copy of their advance directive or advance decision. Don't just think they're not bleeding right now, I don't need it, because you don't know what's going to happen 5 minutes later. If your patient doesn't have a copy on them, ask them, is there somebody at home that can bring a copy into us now? If there is, great, get it brought into us. If there isn't somebody that can bring it into us, you can contact Blood Bank or contact the transfusion practitioners, as we may have a copy in our office or in Blood Bank. If we don't have a copy, the next port of call will be contacting the GP, as some Jehovah's Witnesses log a copy with their GP. If the GP doesn't have a copy, your next port of call will be contacting the hospital liaison community for Jehovah's Witnesses. They are contactable 24/7 via switchboard. But please bear in mind, when contacting them, this is a confidentiality issue, so you must get permission from the patient or the next of kin before contacting them. Please refer to Trust Policy B30, Guidance for the Treatment of Jehovah's Witnesses and Patients Refusing Blood Products, available on Net Consent, for full guidance on any patients refusing blood products. You may have a paediatric that the patient or the parents are Jehovah's Witnesses and they're bringing the child up in the religion of Jehovah's Witness. They may present an advance directive which words something similar to, we are the parents of Jane Doe, we are Jehovah's Witnesses, we're bringing Jane Doe up in the same religion. This document is not legally binding. If you do have a paediatric that is refusing blood products or parents are refusing blood products, I strongly advise that you refer to Trust Policy B30. Also speak to the haematology doctors as they can advise on the most appropriate non-blood management, and also check with the family if they're happy for you to contact the Hospital Liaison Community for Jehovah's Witness, as they are a great guidance for medical staff but also support for the family. Once you have a copy of the advance decision to refuse medical treatment or advance directive, photocopy it twice, both sides twice. One copy to be put in the patient's medical notes, one copy to be sent to the transfusion team. You can either scan it and email it to the transfusion team, email address shown on screen, or put it in an envelope labelled transfusion team and pod it or hand deliver it to blood bank. Never put it in the internal post. Once the transfusion team receive a copy of the advance directive, they put an alert on CareFlow and also an alert on the blood bank computer system. If your patient is attending for a pre-op appointment, do the above at the pre-op assessment, but also remind the patient that they still must bring their advance decision with them when they attend for surgery. We do have these blue no blood wristbands. So if you have a patient that's refusing blood products and has an advance directive, then you can offer the patient a blue no blood wristband. But please remember, if you don't have a copy of their advance directive, you cannot give your patient a blue no blood wristband. Ensure the patient understands the risks of not receiving the transfusion and the benefits of receiving a transfusion. Make sure that they don't want to receive the transfusion, and then if they want to wear the blue wristband, document the patient's full name, date of birth and hospital number on the wristband and then pop that on their wrist. Then document in the patient's medical notes the discussion you have had and what you have done. Remember, no advance directive, no blue wristband. Please also remind the patient that they can change their mind at any time. There are other patients that refuse blood products. They might not be a Jehovah's Witness. They might just not want a transfusion, thank you very much. Or they may be a Jehovah's Witness without an advance directive. We have Consent Form 5. Consent Form 5 is for adult use with capacity. It is printable from the transfusion resource page on KNet. Please do not print the appendix from the trust policy. This document must be completed by the doctor and the patient. Next of kin cannot complete this on a patient's behalf. The doctor must explain the risks of refusing the blood products, the benefits of receiving a blood product, any alternatives, and then what blood products will the patient or won't the patient accept. So will they accept red cells? Will they accept platelets? Will they accept anti-D, etc.? They must document that on the consent form. Ensure that the patient addressograph label or the patient details are completed, and then the doctor must sign it and the patient must sign it. Consent Form 5 is valid per admission episode. So if you complete Consent Form 5 today and the patient comes in again next week, you must repeat Consent Form 5 again with the patient. Again, just to remind you, this is for adult use only with capacity. We also have Consent Form 5.1. This is for adults with capacity that are pregnant, so obstetric patients. It's the same principle as Consent Form 5, so again must be completed by the patient and the doctor. Next of kin cannot complete this on a patient's behalf. The doctor must ensure the patient understands the risks of not receiving a transfusion, the benefits of receiving a transfusion and any alternatives, and then what blood products will they or won't they accept, and then the patient must sign it and the doctor must sign it. Consent Form 5 is valid during the pregnancy from the date of the signature on the consent form and for 42 days after delivery. Again, this is printable from the transfusion resource page on KNet. Please do not print the appendix from the trust policy. Just want to have a quick read of that shot report. Okay, and then we've just got a couple of review questions if you just want to answer these questions, and then we'll carry on afterwards.